Today we're going to talk about all things rhinoplasty. We're going to give our patients as much information as possible on the different techniques, the different types of rhinoplasty, the risks, the benefit, the recovery, the process, and more. What are we going to be talking about today then, Mr. Ullas?
Predominantly, we'll be talking about rhinoplasty, the different types of rhinoplasty, do's and don'ts, who's it suitable for, and try and give you as much information about rhinoplasty before coming to see me in clinic.
There are lots of different types of rhinoplasty: aesthetic rhinoplasty, septoplasty, septorhinoplasty. Just talk us through the different variations and what reasons a patient might choose one or the other.
Okay, and doctors love making things more complicated than it needs to be, and rhinoplasty is no exception. So rhinoplasty is any procedure that changes the shape of the external nose. Septoplasty is changing the shape of the middle partition of the nose. So the septum is what divides your nose into a left and right, and any procedure to that structure is a septoplasty. So septorhinoplasty is when we do both. It can have aesthetic, which means we just want to change how it appears, or it can be due to the functional aspect of the nose. So the nose is there for a reason, so we want to breathe through it. And there's even books on how important breathing through the nose is. In fact, I think it's called Breathe. We often do it for both.
How often would you do a combined rhinoplasty and septoplasty?
So most of my patients require a septorhinoplasty, and the reason for it is the most common reason people come to see me is my nose is really big, I'd like to make it smaller. So if you bring a nose that's big closer to the face, you have to stabilize the external nose onto the septum. You can't do that without altering or strengthening the septum and its junction with the rest of the nose.
Will patients who have a septorhinoplasty, will they always see improvements to their breathing?
No. So some people have nice, open, normal airways and they can breathe through their nose absolutely fine. So in those patients, the surgery is unlikely to improve anything. But there are patients who have very restricted, blocked airways, and in those patients, actually, they are pleasantly surprised by how much it's improved their breathing.
And what about patients who have had trauma to the nose? Is that something you're able to address with this surgery?
Very much so. Certainly in the NHS, trauma is actually the main indication for it. And we see a lot of patients coming in who had various types of injuries, which has changed the shape of their nose or changed the structure on the inside of the nose, caused scarring inside the nose, or sometimes even caused perforations, which is a hole in the septum. And we can reconstruct all of that.
So you talked about septal perforation correction. What is that, and when would a patient need that?
So septal perforations or septal fistulas is essentially a hole in the middle partition of the nose. It can be caused by a lot of reasons, including picking the nose, injuries, previous surgery, cocaine use, many causes for it. And it causes issues. It's a field that can be difficult to reconstruct and difficult to address. There's not that many people in the UK that actually does surgery for septal perforations because of its challenges. And I'm happy to say that we get in Pall over 90% successful closure, which is not something many places in the world can boast. But people with these perforations are often troubled with repeated infections, crusting, whistling, nosebleeds, and at its worst, it can actually make the nose slowly collapse in, which can be quite horrifying, especially if you're 20 years old, and it's the structure in the middle of the face, so it can be very much bothersome.
Why is it such a challenging surgery to do as a surgeon? Why is it so difficult?
Working inside the nose it's a tight space. So you only have from here to here. So if you have a hole in the face, you have all of that space to work around. Whereas if it's inside the nose, you only have the space inside there to work with. And to successfully close these perforations, you need to have a good blood supply to the lining or enough lining left. So there's many different approaches towards it, and it all depends on how big the hole is and how healthy the lining is.
And you've had patients travel from all over the UK, Europe, Canada to come to you. Why is that?
It's more what we're able to offer. A lot of patients are told that there's nothing to be done, or that you can only have a plastic button put in, which can often actually make the hole bigger or not help you at all or cause pain. We, on the other hand, are able to offer some kind of relief to almost every patient. So we do an open approach, which means that almost any size of perforation can be repaired, almost. At the very least, in patients whose noses have collapsed in, we can very reliably reconstruct it so they can actually have a normal appearing nose.
And you mentioned that often you can achieve a success rate of over 90%. What happens to those patients who are perhaps in that 10%?
So our last publication on our data, we managed to get 94% successful closure, and 96% of people had improved symptoms. And that last 2% are people who had only partial closures, but it was small enough that they didn't have any symptoms from the hole. So if you're in that last few percentage of people who don't succeed, it's usually the lining is just too unhealthy. The diseases that was driving the perforation in the first place just wasn't controlled enough. And sometimes it's infection. We can't control every patient. But if you are in that, there are some patients we can try and close it again. And there are some patients that unfortunately we can't do much more for. But if you are coming to see us, usually you've exhausted all the other options.
Even then, those patients who don't get full closure, do they still see a remarkable change in the quality of their life as a result?
If we can close just the front part, the front 1 to 2 centimeters of the perforation, usually we'll remove all the symptoms. So coincidentally, I actually have a very small perforation in my nose, about 2 millimeters in size, and because of its location, it doesn't cause me any symptoms at all. So I have no reason to seek closure for it.
Let's talk about secondary rhinoplasty surgery. Mm-hmm. What is secondary rhinoplasty surgery and why is it so common?
So revision surgery or secondary rhinoplasty is when people have had some procedures to the nose, either to the septum or to the external nose, and it's not gone right, or they've had more problems from it. That's when we do a secondary or revision septorhinoplasty. Why it's more common? Unfortunately, there are a lot of people without adequate training or people who are misled and having surgery done by in abroad, for example. So there's a lot of people going to Albania, Turkey for health tourism, and you don't necessarily get good aftercare. So because of that, they may have problems in a year, 2 years, 3 years, and then they're stuck in what to do. So they come to see us for reconstruction.
And how is secondary rhinoplasty more complex as a procedure than first-time rhinoplasty or first-time septal rhinoplasty?
So revision surgery is incredibly challenging because a lot of the normal structures have been disrupted, which means that parts of the cartilage might be missing, parts of the skin might be missing, and more importantly, everything is scarred. Scarring is the enemy, because if there is scarring, the natural layers of the tissues that we open are just not there anymore and is much more stuck down. which restricts the blood supply, which restricts how much we can improve and stretch and push and pull. That's where the challenges come from. So that requires a very different set of skills because you're thinking about reconstruction, rebuilding the nose. For example, if a nose has been made too small, how do we bring it back up? Or if the tip is pushed up and they need to bring it back down, how do we do that? It's all about forces, mechanics, and basically architecture, but of the human tissue.
And you do a lot of secondary rhinoplasty at Pall. Where did you learn that skill? Do you have to do a certain number of primary rhinoplasties before you can do it?
Secondary rhinoplasty is a challenging field, and having experience in primary rhinoplasty definitely helps, but it's understanding the principles of the nose, understanding principles of reconstruction. Where do we get the blood supply from? What to do when the structure is utterly deteriorated? Those kinds of principles only comes with training. And I was lucky enough to train with my father and in people in Turkey and other parts of the world that have got extensive experience. So I've learned a lot of tips and tricks and what to do when there is nothing there, when you open a nose and there's no cartilage left, when the septum is entirely gone. What do I repair it with? Where do I get fresh blood supply from? All of those things are skills I've developed over the years.
And does your skills and experience in secondary rhinoplasty, does that make you better equipped to do primary rhinoplasty?
Particularly in patients who've had extensive trauma, so had injuries, car accidents, and I've treated a lot of patients who've been professional combat sports athletes, so which is one of my other older hobbies, and they've had their noses repeatedly injured for their career. So to rebuild that is essentially a secondary rhinoplasty, even though technically they've not had surgery before.
Which sports was that? Which martial arts were you doing?
I did karate for about 10 years, and then I did Muay Thai, so Thai kickboxing for a long time, which I really enjoyed. Actually, ended up, even in training, I ended up treating quite a few of the fighters in my gym, actually, which is quite fun.
Were you a qualified surgeon when you were doing?
Yeah, I was in training. So I stopped during my fellowship, and I really want to get back to it. You may notice that I have a few black spots, but that's from various injuries over the years. But it's great fun, and I enjoy it, and I enjoy the people in combat sports. They're actually quite fun people to treat.
If someone does have a fairly active lifestyle, whether that's they're a footballer, they play rugby, they do martial arts, is their nose stronger after rhinoplasty?
I recommend 3 months after the surgery before you go back into combat sports or football.
So which parts of the nose can you operate on, and what are the different features of the nose that you might be able to change during rhinoplasty surgery?
Okay. The most common request I get is about humps in the nose. People are self-conscious of it and they want removing. That's very reliably reducible. We can bring the bony part down, we can bring the cartilaginous part down, and that can be smoothed down into a nice smooth contour. When you feel it, you can actually feel some irregularities, but you shouldn't be able to see anything. So we can very reliably do that. Bringing a nose closer to the face, because for example, if the nose is very large and sticking out from your face, we can very reliably bring it closer into your face. Similarly, the width, very commonly people ask for the width to be reduced. Very reliably we can do that. Making a width broader is trickier and is possible to a limited extent, but not completely. And the other thing people commonly ask is the base of the nose. Now, if you happen to have a very broad base and your nose is closer to your face, actually bringing it out gives an apparent narrowing. And the final level is actually making the base closer with what's called alar base reduction.
Can you tell us what a bulbous nose is?
So bulbous nose or the bulbous tip is what people often complain of, and that can be due to the size of the cartilages of the tip of the nose, or sometimes the width between the cartilages, because just like how some people have a cleft chin, you can actually have a cleft nose, and the cartilages, the ligaments in between them, are actually not as tight as it should be. So you can have this very broad, boxy or bulbous tip. And there's numerous ways of very reliably addressing that with surgery.
What about if the nose is asymmetrical? Is that something you're able to address?
To some extent, but it also depends quite significantly on the cause of the asymmetry. So for example, if it's because the bones have been broken in the past and it's a cross, or if the cartilages is overdeveloped on one side compared to the other, then yes, I can fairly reliably improve that. But it's very important to realize that most people have an asymmetry to their face. So for example, if anyone's looking at me, my eyebrow here is higher than here. And that's because this side of my face is slightly more developed than the other side. And that's natural, that's common. Almost everyone has a degree of asymmetry to a greater or lesser extent.
What about a patient who wants to reduce the size of their nostrils? Is that something you're able to do?
That's a complaint I do hear about. And so we can make the shape of the nostrils different. For example, if a nose is very long and you have an oblong, elongated nostril, as we bring the nose closer to the face, it becomes more rounded. But making a nose just smaller is actually very difficult. We can do some of the alar base reduction techniques, but the limitation is narrowing the entrance to the nose, because that might actually cause you a blocked nose, and it's very difficult to fix if that happens. Or we can create nostrils are nostrils because they have a nice smooth contour. If we disrupt the contour, that can actually be visible. So I avoid it unless someone has a particularly large nostrils.
One thing we commonly get asked is the difference between an open and a closed rhinoplasty. Can you help us understand the differences?
So I tend to do majority of my work open, and the only real difference is a small, discrete cut just there. And as I've mentioned, I have had my surgery, and I show my scar to all my patients. It's so faint, it's hardly visible. And I'll do a whole series of photos of my post-ops to show how small that scar is. Anything you can do closed, you can do open, and anything you can do open, you can do closed. And that is true. But I don't see what you're gaining by doing everything closed. Because the only real difference is that you leave this bit of skin intact, but you cut everything else, and you in fact make further cuts just inside the nose to gain access to the bones and things. So you actually end up with more incisions with a closed approach than with an open approach. In theory, there is some benefit in healing and recovery. In practice, not really. They're both about equally traumatic. It's all about the surgeon's preference. It doesn't really make much difference to the outcome.
Does it make a difference from a pain point of view?
Not at all. Not at all.
There are a few other types of rhinoplasty which we sometimes get asked about: ultrasonic rhinoplasty and non-surgical rhinoplasty. What are the benefits and the limitations to these options for patients?
Okay. So ultrasonic rhinoplasty is basically a device called a Piezo machine, which uses this high frequencies to shave down the bone. In theory, it reduces the amount of bruising that you have after the surgery, but in practice, it doesn't actually make that big a difference. It's used for barely 5 to 10 minutes of the entire rhinoplasty procedure. The whole rest of the surgery is exactly the same. So it's purely the bone work has a very small change, with a very small potential for reduced bruising. The flip side of it is to get the tip of that instrument inside the areas we're working on, you actually have to lift more of the tissues wider, which actually leads to more swelling. So it's an approach, just like I mentioned earlier, there's lots of different ways of doing the same thing. It is an approach of making the cuts in the bone and manipulating the bone, but it's nothing novel or particularly innovative. It's another tool.
And what about non-surgical rhinoplasty using dermal fillers?
So fillers are useful to fill and expand, as the name suggests. So if you have a depression, for example, you have a depression in the middle part, putting a bit of filler there will even it out and lift it up. Far less invasive. Yes, it's sore. It has some potential risks, but it's not surgery. And if you don't like it, you can always have it dissolved. So it's a very reasonable alternative. However, there are some deformities that it cannot address. So for example, if someone has a bump and what they can do is fill above it here to even it out, but that will make the nose start far higher on the face, and that itself can look a little bit weird. So there are pros and cons of it. There's definitely a role for filler in people who don't want to address it with surgery or don't want to take the risks of the surgery or the prolonged recovery from it. But it does have some risks in itself. For example, if the filler is injected in the wrong layer, it can actually occlude the blood supply. So it does have its own risks, but fairly rare. It will make the surgery slightly more difficult as well because it does tend to cause some inflammation, which causes more bleeding. So it's something to discuss with your surgeon, but it's a very, very reasonable alternative.
And how long would a patient's results expect to last from a non-surgical rhinoplasty?
That really varies from surgeon to surgeon, injector to injector, and from product to product as well. So typically you'd have to refill maybe once a year or once every 6 months, depending on what kind of product is used.
Do you find you see a lot of patients who've had non-surgical, maybe once, maybe twice, maybe more, and then come to you for the surgical?
Yes, because if you think about how frequently you'll have to refill it across a lifespan, you can condense it into a one-off investment, which might even be cheaper over the long term. But it's also going through the hassle of the nose changing shape over the course of the year or over the course of 2 years, and then going, oh, you look different from day to day. That can actually be quite bothersome to people. So if they have surgery, they have a result which just ages with them.
And if you are seeing a patient in consultation, do they need to remove their filler if they have any in the nose before they see you?
I prefer to see my patients without filler in because it helps me assess the patient better.
Can we talk about the surgery itself then? So what's involved? How long does it take? What type of anesthesia? How painful is it?
So we do all of our rhinoplasty procedures under general anesthetic. The benefit is that it's much more comfortable for you. You don't realize what's happening. You just have a nice sleep for the duration of the procedure, wake up nicely. The surgery itself will involve if we're doing open, we'll make a small cut just here, lift up the flesh, get down to the skeleton, and then we do our work. The duration of it is really variable. It depends on the work that you need doing. So if it's only a very small bit of a hump there that we are getting rid of, it might be done in an hour, hour and a half. If we are dealing with a much bigger procedure, it may take 3 hours. Very rarely, it may take about 4 hours. But around 1.5 to 3 hours is our average.
How painful is the surgery immediately after and then for the duration of the recovery?
So the pain is really not that bad. I can tell you that from personal experience. Um, Maybe 2 out of 10 pain is what most people describe. It's more of a heavy, tight feeling in the middle of the face, sometimes a bit of a headache. Um, but pain, like throbbing, ow, I've had surgery to my nose kind of pain, is actually quite minimal.
Is that because of the pain medication that is provided?
Some of it, but actually, pain is usually from how mobile a structure is. So in the middle of the face, the nose doesn't really move very much, and because it's so immobile, it doesn't. It's like when if you hit somewhere and you press it, it hurts. But the nose, because it's not moving, it's not wiggling, it doesn't really hurt that much.
Do you find that patients often anticipate the pain is a lot worse than it actually is? Why do you think that is?
I think the idea of big surgery or us having made breaks in the bone, all of these ideas often scare people. But to date, my patients wake up with very little, if any, pain.
What about the anesthesia? Is that painful?
The anesthetic is not painful. It can give you a sore throat afterwards because of the breathing tube. But even that settles down within a few days, sometimes a week or two. But other than that, you don't really have much pain. It's you go off to sleep and then you wake up.
How do you wake up? Do you wake up feeling really groggy? Do you remember what's happened? Do you have any recollection of the last 90 minutes, 3 hours?
So you shouldn't really. It's phenomenally rare to have any recollection. Generally, it's like going to sleep. You have a fairly dreamless sleep, and I've even had patients wake up and they've literally said to me, "Oh, that was a nice sleep." So it can be as straightforward as that. Some patients wake up with some grogginess and tiredness. Some patients have some issues with nausea, but vast majority of patients, they very smoothly wake up.
And would you say it's a fairly safe surgery in the right setting, in the right hands?
Absolutely. We are very careful in selecting our patients. Safety is absolutely paramount. We are not going to do elective surgery, cosmetic surgery, if it's going to be of any danger to you. So it is extremely safe. We do not take any unnecessary risks at all.
Can we talk about the stage after surgery? You've talked about the pain immediately after the surgery, but what does that next few weeks, few months, first year, what does that look like from bruising, swelling, stitches, cast removal?
Okay. So all my patients will wake up with stitches just here and a cast on the nose. We remove that at a week. I usually do this myself, and after a week, you can start blowing your nose. In the first 2 weeks, you'll notice bruising. 80 to 90% will be gone by the end of 2 weeks, and it may be leaving a little bit of a yellowy staining for a few more weeks after that. Swelling, when you take the cast off, you'll see a rough idea of what your nose is going to look like, but by the time you get home, it will have swollen up more, and that's completely normal. All it is that the cast was holding the swelling in, and once it's taken off, it's got more room to swell out. And over the next 6 weeks, 3 months, and 6 months, the swelling will slowly improve. But you can actually still see changes to the nose even after a year to sometimes even 2 years afterwards. I don't put any packing inside the nose. You'll see some photos of people with these big sponges in the nose. I don't do that because it's very unpleasant. I had them in my nose myself, and I don't like having a completely blocked nose, so I don't use them. The downside is that you'll have some oozing of blood for 3 to 4 days, and then it settles down. But the benefit is you can breathe through your nose, even from immediately after the surgery.
Do you find that swelling varies from person to person?
Quite significantly. Some people swell, everyone will swell, but the degree to which you swell is very variable. So I find that Asian patients and revision surgery patients swell the most, and they take the longest to resolve. The bigger someone's nose is when you start, they swells more, because when you're making a nose smaller, it's the skeleton that we alter, not the skin. So it'll take longer for the swelling to reduce. And there is a lot of interpatient variability along with that as well. So the bigger the procedure, the more swelling, and the slower it resolves.
We get asked post rhinoplasty, can you wear spectacles or glasses?
So I've actually created a aftercare information sheet, and I like to make my aftercare as simple as humanly possible, because the more complicated you make something, the less likely you're going to follow it, and the more guilty you feel. So wearing glasses, getting on with your life, not an issue.
What about sunbeds or smoking? What do you typically advise post-op?
So smoking and vaping, I recommend to stop 2 weeks before the surgery and for 6 weeks after the surgery. Smoking is a bit like rubbing hot tar on an open wound. So because the cigarette smoke will come into contact with the nose, so it will affect it. And the chemicals in vaping can affect the blood supply to the nose. So that's why I recommend that.
About use of sunbeds.
Sunbeds. So staying out of the sun for 4 weeks is recommended, but generally just apply factor 30 plus sunscreen and be liberal with it and reapply every 2 hours. You should be fine.
When do you recommend people can go back to light exercise and more strenuous exercise?
So after 2 weeks, I recommend very gentle cardio, so walking around, for example. After 4 weeks, you can start jogging. After 6 weeks, you can go back to anything, including weightlifting. But combat sports, leave it for 3 months.
Is that the same for physical sports like football or rugby? Again, 3 months?
No, well, it depends how rough you are with your football and rugby. But yeah, 3 months if you're particularly aggressive in playing. But if you're just playing, touch football or five-a-side, perhaps 6 weeks is fine.
And from a bruising point of view, how might that change over the first few weeks, first few months after surgery?
Majority of the bruising will be gone. 80 to 90% of it will be gone by 2 weeks. So you will be socially presentable in about 2 weeks. By 4 weeks, pretty much it should all be gone. It's very rare for any bruising to be left over at all after 4 weeks.
If a patient wanted to wear makeup to cover that bruising, would you advise them not to, or is that okay?
After a week, absolutely. Use makeup, no problem at all.
You said after the cast is taken off, patients will get a glimpse of their final result, and then the swelling will start again. Typically, how long might it be until someone does start to see that final result?
This is again variable depending on patient and exactly what was done. Over the first 6 weeks, swelling will fairly rapidly improve. After that, over 3 months, it will improve, but slower than the first 6 weeks. After that, even slower than that, for 6 months. It takes about a year to see the absolute final result, but by 6 months, you'll get most of the idea. So I would say 3/4 of the swelling will be gone by about 6 months.
Can we talk about cartilage graft? So what is cartilage graft? How might patients find out if they need it? Are they able to test themselves? And what are the options if they do need it?
So the majority of patients don't require any grafts other than from the septum itself. So your own nose in your own septum, which will be open and available when we're doing the surgery. However, there are some patients, for example, if you look at my nose, when I press my tip of my nose, it doesn't desperately move very much. but there are quite a lot of patients where you press and it goes easily inwards. That indicates either the tip structures are not directly connected to the septum, or that the cartilages of the septum is actually quite weak. So that makes me more worried that the strength and resilience of your cartilage is not enough for keeping the structures where it should be, or using it for grafting. For example, the tip is very bulbous and I need to flatten it out and make it sharper. I need to have reasonably strong cartilage. And it's in those patients that we start talking about ear cartilage or rib cartilage.
And when might you use ear cartilage versus rib cartilage? What are the main differences?
So I like to think of the nose as having a foundation and an aesthetic. So the foundation being the septum, because that's what all this weight and all these structures are resting on. If you use something weak on a foundation, just like in a building, it will collapse. Therefore, a rib cartilage is strong if you are replacing or rebuilding a septum. But for the aesthetics, you don't need as much strength. You actually need a degree of malleability and flex to it, in which case ear cartilage is absolutely fine. In the majority of cases, this is more of a revision thing, where the cartilage in the nose has already been used up by previous surgery or infection. But in the context of someone who's had a lot of injuries, for example, combat sports athletes, then we may need to take some cartilage.
And does the use of cartilage, does it make the operation more complicated, more painful?
With the ear cartilage, not really. It takes 5-10 minutes to take cartilage from the ear. It doesn't change the shape of the ear, and the scar is behind the ear. So it's very, very minimally invasive. The rib cartilage can be done I've done it as fast as 15 minutes, but sometimes it can take an hour, depending on the patient's shape and size, and how healthy the rib cartilage is. There are some people where the rib cartilage is turned into bone, in which case we can't use it at all. So the rib can be sore depending on how it's done. The majority of my patients have said, yeah, it's a bit sore, but usually when I'm straining or coughing, then it can be a bit sore. And that can last for a few weeks. The ear is not too painful at all.
And does it alter, would somebody be able to look at your nose post-surgery and notice that external cartilage has been used, or it's unobservable?
With ear cartilage, definitely no. With rib cartilage, they shouldn't tell from the appearance, but rib cartilage tends to be stiffer than a normal septal cartilage or a normal nose. So that is something I always warn my patients. If I have to use rib cartilage, it will feel stiffer to touch.
And do patients, do they mind that? Is that a common objection?
It's if I'm seeing a patient and talking to them about rib cartilage, they usually don't have many other options, because the septum has been used up or too badly damaged for me to reuse. So in those patients, it's either we use this or we don't do the surgery at all.
But it sounds like you're saying the use of cartilage isn't something to worry about or be concerned with.
No, it's your own cartilage. Yes, there are other alternatives of irradiated cartilage, which I don't desperately like, or frozen donated cartilage that somebody has donated and it's been washed and cleaned, which is good, but it's somebody else's tissue. Even though there's nothing living inside it, it works almost as well. But your own rib is available in 90% plus of patients, and it's perfectly healthy and easy and very safe to harvest.
And the test you said that patients can do, can you just talk about that again? So you put your finger on your nose. What do you do?
Very much. So if you touch the tip of your nose and you press inwards, So you can see my nose does not, and I'm putting a good amount of force actually, it doesn't really push in. But in people with weak cartilage or the tip not being articulated to the septum properly, the nose will go inwards very far.
And if I press on my nose and I can't quite push it all the way, or I can't tell, does that mean I'm more likely to need it?
If the nose is not moving, it's fairly strong. If the nose is pushing in quite a lot, then the cartilage is probably weak and you're more likely to need a graft.
I assume this is something you'd go through during the consultation stage.
100%, absolutely. It's not something I spring on you unexpectedly.
So prior to the surgery, you'll go through the options with the patients.
Exactly, to see what is reasonable, what is achievable, and what's acceptable to you.
Can we talk about the consultation process then? So if somebody is interested to learn more about rhinoplasty, how does that consultation look when they come to see yourself?
So it's a very, very relaxed atmosphere, and I just start with what is it that you're bothered by? What is it that you're looking for? And a lot of patients come in thinking, I'm going to tell them. It really doesn't work that way. It's very much about what is your worry, what is your concern, and what would you like addressing? And that lets me gauge on, is it something I can address surgically, or is it something that's better treated non-surgically, or is there not a problem at all? And then we work around it. We assess your nose, make sure there's no functional element to it, take the history to make sure there's no adverse issues like inflammatory diseases or anything that can affect the tissues of the nose, or your overall health. And then we'll assess with some photos. So I'll take some photos, and I have some software where I can morph and manipulate it. So we can go, and I go through it with you. So sometimes patients say, oh, can you bring the nose a little closer to my face, a bit further away, a bit narrower? And I just work it through individually until we find something that you like. And that is our goal. It's not a guarantee, because there are too many factors in the healing process, in the surgery, walking into doors after the surgery. All of these things can happen. I can't control that. But that is the goal that we're setting for what you want to achieve. Once that's done, I always send those photos to you, so you can have a sit down, think about it. Is this what you like? Is this not what you like? And there's absolutely no pressure. If there's something you want to ask, by all means, you can ask through our coordinators or through my social media, and we will just rediscuss it, and we even manipulate it again. Sometimes people just need to see that actually, if I brought the tip up too far, it doesn't actually look that good. And sometimes you just need to see that photo, and that's absolutely fine. Because ultimately, it is an elective procedure. There is no rush, and you have to be happy with what we are trying to achieve. And you need to be sure that I understand what it is that you're looking for.
So you ultimately work with patients to design the nose that they want. You tell them what is and isn't possible, but it's a very collaborative approach.
100%. It should be. I can't imagine it not being collaborative, because ultimately you are an individual. You have a particular aesthetic that you enjoy, and I work within a spectrum of what I think is possible and what I think is natural.
Do you encourage patients to bring photos to consultations of the noses that they want to have, or similar noses that they want to have?
If it helps explain what it is that you're looking for, then yes. But if it is that you say, oh, I want Nicole Kidman's nose, then that's not something I particularly encourage, because you are not Nicole Kidman. So you don't need to, your face is never going to look exactly like that. So I strongly prefer to tailor what we're trying to achieve to you and your aesthetic. And if you have an inspiration, absolutely, but not saying if this is exactly what I want, or show me a catalog of what I want to pick from.
So I guess during the consultation, after you've done the assessment, after you've talked through what the patient wants, will you give the patients various options, you'll give them the surgical plan. How does the rest of that consultation look?
Once we've established the goal of what you want, then we go through how do we get there. So is it an open approach, closed approach? Is it a septorhinoplasty or a rhinoplasty alone? And do we need any grafts? I go through all of that in great detail. We'll go through the surgery, the steps, the recovery, how you're going to feel afterwards, and then we'll make mostly a shared decision. Majority of my work, as I mentioned, is done open, and I'll go through the pros and cons of that. I'll go through the risks of the surgery, and then I'll take you through to, depending on whether you have any questions, I'll answer all the questions you have, and if you have any questions afterwards, I'll get the coordinator to message them to me, or you can message to me directly. I really don't mind. And then I'll take you to a dedicated coordinator who will talk you through pricing, financing, dates, and there will be your dedicated port of call for any and everything until the day of surgery.
If patients, after they've seen you and after they've seen the coordinator, if they realize they have further questions, can they see you again?
Absolutely, absolutely. I don't formally request a second consultation for the majority of my patients, but if you have questions, absolutely, we can have another consultation. We can talk through any doubts you have. If you're anxious about something, you just want to get some reassurance, absolutely, we can do that at any point until the day of your surgery.
It's a big decision. People need to be comfortable with what they're choosing to proceed with.
Exactly. There is no pressure. There is no rush. This is something you need to feel absolutely ready for.
Okay, so it sounds like a very thorough consultation process. It's how long do you typically take with patients?
So my consultations are allocated in half an hour, but some patients don't need as long. Some patients need a bit longer. And I will never rush you, because ultimately I want you to be comfortable with and make sure that you have all your questions answered.
And patients can obviously ask yourself more questions. They can ask their coordinator. They also have the patient community group. What is that?
So Pall has a very holistic approach towards their both preoperative and aftercare support services as well. So there's a Facebook community that allows you to talk to current or past patients and get tips, tricks, how they recovered, anything they found helpful. If you are having some doubts about something that's happened or a question that's happened in the consultation, you can always ask those questions there, and you can have honest opinions from everyone else. And this is very much a private, closed group for patients only. There's no other surgeons or anything there.
Tell us a bit about yourself.
So I come from an otolaryngology/ENT background, and then I did a further fellowship internationally in facial plastic surgery. So my main caseload here is rhinoplasty, complex rhinoplasty, and I also do work on scars and facial nerve palsy as well.
Let's talk about you first. So why ENT? Why facial plastic surgery?
ENT, for me, most doctors find their path at some point, either in medical school or later in life when they do rotations. I was a bit unusual in that I did a work experience with a gentleman called Professor Nick Jones in Nottingham. He's long retired now, but one day with him was enough. I knew I wanted to do this. He was an ENT surgeon who specialized in facial plastics. He was one of the big pioneers of facial plastics in the UK, and he was a genuinely inspirational person. I loved how he did his work, the variety of it, his attitude, the way he thought about things. It was just really exciting.
And you have one other mentor in your life. Who's your other mentor?
The other mentor, coincidentally, Prof. Jones was his mentor as well, is my father, Professor Raghavan, who happens to be an ENT and facial plastic surgeon who also works in Pall.
How does that dynamic work? Father and son, rhinoplasty surgeons.
Working with your family is always challenging, but it's also fun because we bounce off each other, we work with each other, we push each other. I've learned extensively from him, but we can also say, hey, why are we having this challenge? And I've come across this solution. Do you think it works? And combining my broader scope of practice and his experience, we make things more modern, more forward, more innovative.
You make it sound straightforward to get to where you are, but it isn't. What is involved in going from deciding you want to be an ENT facial plastic surgeon to being an ENT facial plastic surgeon?
So as I mentioned, I made that decision very early in life when I was 16. So from there, I knew exactly what I needed to do, which was get into medical school, get into the right type of foundation program, then to the core surgical training, then to my higher surgical training, and then doing a fellowship. I lay it out and it sounds really simple, but actually it's quite difficult to get through all those hurdles straight away. And I've been very lucky actually that I managed to get through all of those hurdles without losing any time. So I am unusually young to have gotten through all that training and to get that experience, which my old bosses constantly reminded me of. But I managed it. So altogether, maybe approximately 15 years from the beginning of medical school to finishing my high surgical training, and then another couple of years for my international fellowship as well.
Where was your international fellowship?
Did partly in Turkey, partly in the States, partly in India, and partly in the UK.
How does that help seeing rhinoplasty across the globe?
It was rhinoplasty and the other procedures as well. So everyone has a different approach to doing things. It helps me understand different ideas of approaching to the same thing. In facial plastics, it's not a one-size-fits-all. It's very much an individualized approach. So I know 10 different ways of doing one maneuver to achieve a result, because not everyone's anatomy, not everyone's cartilage, not everyone's tissue will work in one maneuver. You'll have to do it in a different way for a different person. So in every patient, I will achieve different things by doing the same maneuver in a different way. And having that international perspective has really helped build the repertoire of skills I have to achieve these things. However, in the consultation, we're actually looking at the end result of what you want to achieve rather than where you are right now. So it's not an absolute issue, but I would prefer to see patients without filler. On the day of surgery, you absolutely must have had the filler dissolved, ideally a week to 2 weeks before, because that does change how I gauge things in the surgery.
You've talked about your world as a surgeon. What about outside of the hospital? What do you like to do?
I have a wide scope of interests outside. Yeah, I have, from my family life, I've married, no kids yet. I have 2 dogs though, who are very young and take up plenty of my time. But also I enjoy painting miniature models. So the nerdier of the audience will remember things like Warhammer, which yes, I do, and I have an entire room dedicated to such things. I've even actually won a competition for painting some time ago in the amateur category, because I am still very much an amateur. I also brew my own beer, which is an odd thing for a doctor to be doing, but I very much enjoy it, and I enjoyed the final result from it. And actually, a lot of my colleagues seem to enjoy my brewing as well. So yeah, those are my main interests.
As long as it's not before the operating list.
Most definitely not. Most definitely not. No, I do not drink before or after the surgery.
Do you find then that the artistic side of you helps with the surgical outcomes you're able to achieve?
100%, because aesthetic surgery is very much an art form. We cannot reduce it just into numbers and lines and maths and computer simulations. It's the beauty of art is within its imperfections. It's within its brush strokes. It's within its flourishes, and that's what gives you the difference between something made by a computer and something genuinely artistic.
You're actually unique as a rhinoplasty surgeon in that you've had a rhinoplasty yourself, correct?
Very much so. So about 10, 12 years ago, I've had my nose done. I had a slightly disproportional nose, which possibly affected my confidence a little bit, and actually did have some breathing difficulties at the same time. I was not entirely aware of it until after the surgery, when my breathing improved quite significantly. So that was a big surprise for me. So I speak to all my patients in the first person because I have experienced exactly what you're going to go through, and that's actually helped me inform very much how my post-operative care is to improve the experience as much as possible for you.
Have you come across rhinoplasty surgeons elsewhere that have also had a rhinoplasty?
Weirdly, no. I've seen the relatives of some rhinoplasty surgeons who've had it, but I've not actually met another surgeon who coincidentally had it.
Do you find that patients resonate the fact that you've had the surgery yourself, but you're about to potentially perform on them?
I think I think a lot of my patients appreciate that I can empathize with them on their reasons for choosing the surgery, and that they know that I've gone through it. So it's not a experience where a doctor is telling them, "Hey, it's going to be a sharp scratch," that old lie that every doctor uses. So I know exactly what it feels like and what is going to be the recoveries like, and how to go back to work, and what to avoid and what not to avoid. And that seems to help a lot of people appreciate it.
If a patient wants to see you or discuss their rhinoplasty goals, where can they find you?
You're more than welcome to make appointments with me in Manchester, Newton-le-Willows, Liverpool, or Leeds.
Fantastic. It's been great to have you here. Thank you very much.
It's been great to be here. Thank you.